Hello, everyone, and thank you for joining. Welcome to the Breast Cancer and Women's Health Awareness webinar. I am Alicia Jones, the Health Improvement Manager at Wellhead, Louisiana. Before we begin, I would like to take the opportunity to remind you all to maintain webinar etiquette. Also, after the presentation, we will have a Q&A segment. Someone from our Well Ahead team will address your questions. Our disclaimer informs the Louisiana Department of Health, employees, contractors, affiliates have no actual or potential conflict of interest in relation to this program's presentation. The content herein is intended for general guidance, not as legal advice. Laws and regulations take priority if there are any differences. Our LDH's secretary or surgeon general only can give official statements. LDH cannot speak for other government agencies. And if you need legal advice, you should consult a lawyer. You can see the learning objective for this presentation on your screen. The intent is to drive collaboration throughout the state that connects communities to tools and resources that can improve the health of our residents where they live, work, learn, play, and pray. Before we get started with today's presentation, we will hear from our wonderful Bureau Director, Dr. Nancy Lowenthal. Take it away, Dr. Lowenthal.
Well, thank you so much, and good afternoon, everybody. I want to welcome you to today's webinar on women's health, acknowledging that October is both Breast Cancer Awareness and Menopause Awareness Month. Our webinar today will be primarily focused on women's hormonal changes as we age, especially on the life stages of perimenopause and menopause and its effects of decreasing estrogen levels on women's health. Well Ahead Louisiana is the chronic disease prevention and healthcare access arm of the Louisiana Department of Health. Our vision is to reduce the burden of chronic disease and ensure quality healthcare for all Louisianans residents. We work alongside leaders at key organizations across the state, such as child care centers, colleges, universities, faith-based organizations, restaurants, schools, work sites, and healthcare facilities. Helping to create environments in which everyone can be healthy, we believe that everyone has a role in connecting Louisiana communities to a healthier future. We are committed to educating and empowering leaders across the state with reasonable steps to move Louisiana's health forward. However, before we dive into today's topic, I want to provide a few critical points about breast cancer, as it is the second leading cause of death for women in Louisiana, and 1 in 8 women will develop breast cancer in her lifetime. Note, men can also develop breast cancer. However, the risk is much lower at 1% of all cases. So most critically, breast cancer prevention and early detection are critical. Be aware of your body and and get regular clinical screenings, including mammograms, every 2 years for women over 40 and older. Please consult your clinicians to know what is right for you. Secondly, know your family's history. And lastly, stay active. Even a 20-minute daily walk can reduce your risk. And if you have been diagnosed with breast cancer, please stay hopeful. Seek support, focus on your emotional well-being, and very importantly, follow your treatment plan for the best chance of cure and survival. Again, we welcome you to today's webinar, and I'll turn it back over to our moderator, Alicia. Thank you.
Thank you, Dr. Lowenthal, for the great welcome. I will now move into the speaker introduction. I am happy to introduce today's webinar speaker, Dr. Christina Lord, is a native of Vernon Parish and is honored to serve our community as the Regional Medical Director for Region 6 Office of Public Health. After having completed her obstetrics and gynecology residency from the University of Texas Medical Branch, Galveston, in 2004, she proudly returned back to Central Louisiana to open a private practice OBGYN office in Leesville and has been taking care of women in rural Louisiana since then. She feels that having years of study within the Department of Microbiology at LSU Baton Rouge and then in medical school at LSU Health Sciences Center Shreveport provided a valuable foundation on which to better understand public health outcomes in our state. Dr. Lord currently volunteers on several committees within the Louisiana State Medical Society, is the vice chair for the Louisiana section of the American College of Obstetricians and Gynecologists, and is the past chair 2023 for the Greater Vernon Chamber of Commerce. As a quote and words from Dr. Lord, finding a way to positively impact the lives of the folks that live and work in my area is what it's all about. And I want to continue to do that, says Dr. Lord. Having a local health advocate is to our advantage as we work together to support our OPH mission of protecting and promoting the health and wellness of all individuals living in Louisiana. Before we proceed, please be advised. Some of the content shared today may contain some profanity. Viewer discretion is advised. I will now turn it over to the presenter. Welcome, Dr. Lord.
Good afternoon. Thank you very much for that kind introduction. And I will try to not use profanity today while we're talking about this very important part of women's lives, which is having to do with our transitions through perimenopause and into our menopausal years. I do thank you, Dr. Lowenthal, for starting out acknowledging that this is Breast Cancer Awareness Month. And then on top of that, we throw in these conversations about menopause. And sometimes our messaging between those two topics can be a bit challenging as we treat patients. You all can't see me today. Normally, I would have on a pink outfit giving a talk with breast cancer, but I do have on blue today. And I just learned that these true blue colors are for Menopausal Awareness Month, but as we gynecologists across the state talk about menopause and all of the symptoms and potential treatments that we can offer now, we want to make sure we also include in this space our patients and family members and community members who are survivors of breast cancer and really include them in ongoing conversations about how do we take care of the aging woman who has survived breast cancer, and then what do we do to also continue to care for her as she is menopausal. So anyway, that's a little bit deviated from how I wanted to start today, but I think it's relevant to what has already been said. And this is an ongoing conversation. I am so happy to talk about this today because I feel like for the first time in my career of 25 years that we have some new data to really shape our discussion and then in the years to come to shape what treatments and therapies we might be able to offer to patients. Now today you see under my title, Menopausal Awareness Month, the quote, "We Do Not Care Club." I was scrolling like so many of us on social media, and back in May or June, I came across this post from a woman named Melanie Sanders. She's from West Palm Beach, Florida, and she posted, and I don't know what she does for a living, but my understanding is one day she went to the market and was just kind of fed up with her menopausal, perimenopausal status. And so she just very spontaneously posted a We Do Not Care Club first video. So she's the founder of this. And are we able to just show the clip maybe of her, even if we can't have sound, so that folks can see her face and perhaps go on their own and take a look at what she does for us in the world of awareness. Clearly, she's not there to offer any treatment guidance, but she is a well-known person across the United States now that really is helping to talk about menopause. And that's what I want to do today, is just to spend a little bit of time with you to talk about menopause, because our talking points have changed in my career. And then I think so many of us women who are in the world of medicine also are going through those stages of our life. And so all of a sudden we're demanding that there are additional studies and data points that we need to look at. And I'm going to talk about those in just a minute. So this is Melanie, and we're sorry to report we can't get the sound to attach for us today. But she has a number of these posts, and she really talks about that our whole lives we put other people's needs over our own as women a lot, and trying to balance our own needs versus everybody else around us, their needs. And as we transition through menopause and our estrogen and progesterone levels fall, our ability to cope changes. We just don't have the energy, and we just don't have the patience to cope the way that we once did. And so her posts are hilarious, and I give her lots of credit for opening up the conversation. And that's where my talk is going today. So thank you for playing her clip, and I hope everybody gets a chuckle or two. I died laughing multiple clips through her page. So anyway, I invite you to go find her, Melanie Sanders, and it is called the We Do Not Care Club. And since she opened her first online, social media club, there have been so many We Do Not Care clubs pop up over the nation. I have no idea if we have a Louisiana We Do Not Care club, but anyway, I hope somebody after this starts one. So invite me and I'll join in. So like Alicia mentioned, I have spent decades of my life devoted to women's health. And I will preface this talk today by saying the first half of my own career was really focused with maternal health. And I think there are lots of ongoing conversations that are very valuable in that maternal health space. But I do remind everyone that not all women choose to have children. I am one of those. But we all will go through menopause. And so as we look at how do those decreasing estrogen levels impact us, and more importantly, contribute to chronic disease, that's where in this well ahead space, I think this talk really kind of dovetails nicely into what you all are doing. And I appreciate the work that your team does every day. Just a housekeeping note here with the definition of perimenopause and menopause. So these definitions have not changed on paper, but in the world of gynecology, they have changed quite a bit. So we used to ignore women until they had no period for one whole year, and we called that menopause, and we said, yep, you haven't had a period for a year, so you're officially menopause. But the majority of the suffering occurs in those 8 to 10 years before she has her last period. And so if we think about the textbooks that have talked for decades about a woman who the average is age 50 where they have their last period, or we have our last period, then those symptoms of perimenopause are going to start 8 to 10 years before that. So when I have a 40-year-old woman telling me she's having symptoms, when I was having symptoms at 40, and I'm in my 50s now, I was told myself as a gynecologist by another gynecologist, you're too young to be having those symptoms. And irate. I left that office upset. So let's not do that anymore. And that's really, again, what today's awareness is about. So again, if we think about what's on the screen right now, let's say a woman stopped her period at age 45. Well, then her symptoms might start at 35, okay? And then there is a condition in the world of gynecology that we call premature ovarian failure. And that, by definition, that means that a woman has her last period at 40 or younger, okay? But that definition doesn't often talk about if her last period was at age 40, then again, look at what we have on the screen. She may have started having symptoms as early as age 30. So it's very relevant for women over 30 to understand that when they start having some weirdness, we, as a larger community within the chronic disease space, need to be thinking about what are her hormone levels doing, and as they're declining, can we help and can we prevent disease from a much younger age group than what we typically have thought about in this space. So next slide, please. So this is just a frame of reference because I'm a visual learner, and so this is an incredible slide for me. So the first graph, you can't see my pointer, I don't guess, but in the first graph, it says female hormone life cycle at the top, and I mean the graph to the left. And you see estrogen, progesterone, testosterone in the darker yellow space. That's the reproductive years. So all three hormones are relevant for female health. And then the lighter yellow space is perimenopause. That's that 8 to 10 year mark that we're talking about, okay? So you can see that our hormone levels, specifically estrogen and progesterone, plummet during those years. And then once we have that last final period, and we textbook that say you're truly a menopausal person at this point, those hormone levels are flat, they stabilize, but they're very low. And so suffering does continue, and some patients continue to have some of the symptoms that they had during those perimenopausal years, and I'll go into that in a few minutes. The middle graph. Now, this is just a snippet of time over 180 days in the world of a woman, okay? So premenopausal, before age 30, let's say, we call it our cycle because these lines talk about how the hormonal levels shift every month that we have our cycle, our period, okay? And for most women who are having a regular period, that cycle of hormones looks very regular, okay? Now skip down to the bottom of that middle graph where it says postmenopausal. Those 180 days, again, the hormone levels are pretty flat. They are actually low or very, very low, but they're stable. Now look at the middle portion where it says perimenopausal 180 days, okay? And then go all the way to the right part of the screen, and I blew that up, so it says perimenopause 180 days. These lines that look like a kindergartner scribbled them all on it, this is the hormone pattern for the 8 to 10 years that we are transitioning through perimenopause. Okay, and so we call that the zone of chaos, which is why Melanie posted what she posted. So two take-home notes here. One, there's a lot of talk in the world of medicine about, oh, I'm gonna go get my hormones checked, okay? If you try to check hormones during that 8 to 10 year time frame and they look like this scribble, the hormonal levels are not adequate to help us diagnose perimenopause, and nor are they diagnostic of menopause. And so I tell people in the world of medicine all the time that are helping to take care of women, if they're over the age of 30 or 35 and they're telling us they're having some symptoms, getting labs back that looks normal do not discount her symptoms. So basically, please listen to your your sister or your friend or your patient because they're telling you something is not right and they need someone to validate that something is not right. And yes, it is a natural aging process, but it's still a level of suffering. And we need to identify it earlier. And of course, in our world of the Office of Public Health and Department of Health, figure out how do we implement preventive practices at a much earlier age during this perimenopausal 8 to 10 year lifespan. Okay. The other thing here, and one of my slides will talk about symptoms in a minute, but look right here with all of those hormonal crazy shifts. What do you think the heart is doing when your hormone levels are doing this? Right? It's getting an irregular pattern of stimulation from estrogen and progesterone. And so while we talk about breast cancer and deaths related to that, I do tell patients all the time, let's pay attention to the heart. And I'll talk about that in a minute. But when you look at this scribble here, that's why the heart is a little bit more likely to suffer than some of our other organs because of that signaling that's coming from those irregular hormone patterns. Okay, next slide. Okay, this is a slide I love because it's a frame of reference. I don't know about y'all. My spouse, he is in his mid-50s, and we talk about men's aging processes versus women's aging processes all the time. Okay, and when we look at the red line, that's the female estradiol hormone level. Again, you see from the ages of 20 to 50, that yellow phase is our reproductive years. And then when we get to about 50, we really see that sharp decrease in our estradiol levels. And then our male counterparts, friends, family members, will talk about their testosterone levels falling over the course of their aging process. And while it does fall some, we women could like really advocate for people to pay attention, because when I say I'm having a tough time because my estrogen levels have fallen, this chart really shows and highlights that I'm not being dramatic. This process is dramatic. And if we're going to be supportive of our male folks and their aging process, then when we look at our line and our graphs, we should be very supportive of women during our own aging processes. And that means giving yourself grace too. I have to have that talk with myself every day. Like, give myself grace. I am exhausted and I cannot get everything on my list done anymore. So I just have to go to sleep at night and try to get up in the morning and do the best that I can. Okay, next slide. Okay, what are the symptoms? So symptoms, the ones that are with the bullet points, these are the ones that like everyone who talks about menopause talks about, right? But now with new research, we're seeing that there are like 30 something symptoms that go along with menopause, okay? And I mentioned the heart earlier. There are a lot of women in their 30s who will start having some palpitations, and that's from that irregular hormonal response to the heart. So don't forget that just an occasional weirdness is likely a trigger from some hormonal disruption that's starting out in our 30s and early 40s. So fatigue, weight gain, anxiety, depression, panic attacks, I'm going to read them all because they're all important. Sleep disturbances, sexual dysfunction, heart palpitations, hair loss, itchy skin, dry mouth, dry vagina, leakage of urine, digestive issues, more headaches, dizziness, tingling in our extremities, and the list goes on. So I was a teenager who really judged my mother harshly for all of the problems she would tell me every day, like all of them on this list, right? And so now I'm like, darn, I had no idea she was experiencing all of this. And so when we have our adolescent girls go through puberty, and their hormones are all over the place and they're throwing temper tantrums and they are crying and doing all of that stuff, that is their body transitioning into those reproductive years. And a lot of us will say, give her space, let her alone, be patient. This is a transitional time for her. She's going through a lot. Well, I now argue on the other side of life, we too are going through all of that, just the reverse. So again, give everybody the space they need because they really are doing the best they can most of the days with the symptoms that they're having. Okay, next page. Or next slide. So this is the most interesting chart on our talk today. There are thankfully new data points and new statistics coming out that talk about different subsets of our female population and what they are experiencing among different groups of women. So when we look at this, obviously in the far left column, it talks about which group of people and which minority subset of our population are with some new data talking points. The average age here, that is meaning the average age that group of women may have as their last period. Okay, that's not perimenopausal years, that's last period. And you can see quite a bit, actually maybe 48 or 49 years when they stop having their period. Then the most severe symptom is different from over on the very right that says most common symptoms. So most severe symptoms are going to be that Black women feel like and tell us that the hot flashes are really causing the most suffering for them. Okay, and look, I'm seeing Alicia shake her head, and I believe you, right? I do, I really do. Our patients that are of East Asian descent, they are talking about heart discomfort, and what does that really mean? We don't really know exactly what that means, but there's a study there, right? There's a study actually in all throughout this presentation, but our patients of the Hispanic communities, they talk about loss of hair, skin changes, and then women from Middle Eastern communities, weight changes, Native American women, painful sex, South Asian women, weight changes, Caucasian women, weight changes. That's different than the over to the right. And I won't go through each one of these bullet points, but I find this fascinating because I hear women gaslight other women all the time. Like, you're having hot flashes, I don't have hot flashes, therefore your hot flash, right? And that implies, therefore your hot flashes, you're being dramatic about your hot flashes, right? Or I don't have painful sex, so what's your problem? Like, you just don't like to have sex, or whatever it is. I hear it with my groups of women all the time. And so I would love to change that talking dialogue a little bit and say, man, I'm glad I don't have hot flashes like that. Or, listen to our friends and family and say, it sounds like you're starting your perimenopausal phase, and go see a doctor about that, because it's not just about these symptoms on this screen. Used to, we would treat for the symptoms on this screen. What I'm advocating is that we treat in a preventive way when they start having any perimenopausal symptoms, to look at their overall health from a chronic disease perspective, so that we jump on board immediately when perimenopause starts, so that we can prevent diabetes better and we can prevent heart disease better. And then we'll go from there. And obviously I'm preaching at this point, but let's move on to the next slide. Okay, so we already talked a little bit about breast cancer being the number 2 killer of women. And in Louisiana, like the rest of the nation, the number 1 killer for women is cardiovascular disease. And as those estrogen levels decline, our risk of heart attack, stroke, all of those cardiovascular diseases goes up. Now, a lot of people say, why? Well, we have new data that shows that as the estrogen levels start to decline, the flexibility of our blood vessels starts to stiffen, okay? And then estrogen in itself, endogenous, like the estrogen that our body makes, is anti-inflammatory. So as those estrogen levels start to go down, we develop more inflammation, and therefore that can trigger some cardiovascular issues. There is an amazing cardiologist out of Georgia. Her name is Dr. Jane Morgan. She does podcasts. She does all kinds of social media posts All those are free. But Jane, and it's spelled Jayne, I've never met her, but she talks a lot about declining estrogen levels and cardiovascular disease. She is an advocate out there talking about how menopause is its own risk factor for cardiovascular disease. And I would love over the next year or two for us to develop more programming talking about that specifically. But she made a good point in a podcast that I listened to recently. And her point was that for my whole life of medicine and for her whole life of medicine, and she's not, we're probably about the same age, she commented that when we talk about women's health, it's always in reference to reproductive health. You know, we really don't talk a lot about all the other diseases that women have, and certainly cardiovascular disease is what's killing us. So to separate that conversation, time to do that. It's time for us to also encourage more women, and specifically women of minority groups, to participate in some data and some studies, because only then can we start to change the way that we treat women. When I look at specific cardiovascular events in Louisiana, and one of you on the phone call may have this data point better than I do. I think the number of women that die per year in Louisiana that's specific to heart attacks is 11,000-ish women per year. And again, my AI Google search may have given me the wrong data point, but it is important for us to look at what is causing the most severe disease and most severe outcomes in women, and focus a little bit more on that. And I would argue that menopause is now a major conversation to be had about women in that heart statistic. For women who are going through menopause, if you look at the population data for Louisiana, and let's say the population of women over 40 in Louisiana is about 1.2 million, then when we look at how many women any given year are in perimenopause, that's 500,000-ish women any given year in perimenopause. So think about our data points with that many women across the state, that we have the capacity to improve improve our preventive health strategies to positively impact their chronic disease. And so that really is the take-home message I would like everyone to have from today. Okay, next slide. Okay, so when we think about chronic disease, these are the major groups of disease that those decreasing estrogen levels specifically impact. So osteoporosis, we talk about that all the time, but I would argue that we would start getting bone densities far earlier than age 65. And when we think about our bone health, simple things like making sure folks get their vitamin D levels, and making sure that women understand what weight-bearing exercises are, very, very important there. 1 in 4 women, depending on what study you read, 1 in 4 women who break their hip die that same year. That's huge. Okay, some reports will say 1 in 3 women who fall and break their hip die that same year. So that's terrible, and we can do better with that. When we think about neurological disorders, the regions of the brain that are responsible for memory and for mood are the ones that are most negatively impacted by those decreasing estrogen levels. So that's why women talk about brain fog. That's why they talk about, oh my God, I'm losing all of my words when I speak. Today, before getting on here, I'm like hoping and praying that I don't lose my words in the middle of my conversations. When we look at autoimmune diseases, for women who already have autoimmune diseases, their symptoms of those diseases get worse, because with lower estrogen levels, they develop more inflammation, and that negatively impacts their autoimmune status and response to medicines. For those who are not already diagnosed, we start seeing rheumatoid arthritis and all of these lupus, all these diseases that we group into autoimmune diseases, but that is related to decreasing estrogen levels. If we think about genitourinary, we could have a whole talk on this one day, but what I mean there is when women start having lots of urinary tract infections, that's because of the vulvar vaginal health that's related to decreasing estrogen levels. And so we need to direct care to that localized area for her, and that will result in less bladder infections. Women talk about leaking urine and they giggle about it, but really we're all super embarrassed when it starts happening to us because we're like, oh my God, did I just leak on myself? Like, this is insane. And so that happens and we don't talk about it, but we have to talk about it more. And then in the same category is painful sex. We don't talk about that a lot. Again, I'm a gynecologist. I talk about it all the time, but I don't want to not say it today because it's important for me to say what is actually happening to women. Now, let me tie in osteoporosis and genitourinary disease real quick, okay? As women get older, we start making trips to the bathroom in the middle of the night more. You can't sleep through the night, get up a few times a night. You're groggy, you're not sleeping, you're fatigued, you're disoriented, you're dizzy, all the things we had as other symptoms. And then it's the middle of the night, the poor lighting, your eyesight's failing you. I mean, it's this whole like syndrome. And then you fall on the way to the bathroom or the way back from the bathroom and you break your hip and then you die that year. So this is, again, from a preventive standpoint, making sure that we treat as we start seeing these symptoms is very important, to not get to those endpoints that are reactive in women's health care rather than being proactive. And musculoskeletal disorders, if y'all have ever heard of a woman talking about a frozen shoulder, okay, she doesn't remember injuring her shoulder. She didn't pull on something. She has no idea. She didn't sleep on it wrong. She just all of a sudden ended up with a frozen shoulder. We are starting to see some data come out about how cartilage and tendons do not repair after these estrogen levels start to fall. And more importantly, all the things we do for men when they hurt their shoulder or their knee don't necessarily make that better because we're asking a body part that's damaged somehow and also not able to repair the way it used to really move and stretch even during physical therapy. So again, we could do a deeper dive into any of these topics, but I think I just want to hit those as highlights today. Okay, next slide. So obviously I'm asking for us to call to action, right? If we're going to improve health rankings, women are half the population in our state. And then for women over 40, that's about 1.2 million women. And so changing the dialogue is important, changing the way that we view preventive medicine for women over 40, and then having more of these conversations and doing those deeper dives with all sorts of healthcare providers. One of the things I learned recently when we think about cardiovascular health, for women, they always say, oh, these are atypical symptoms of a heart attack, right? Well, why are they atypical if half of our population is female, first of all, okay? And they're atypical because in all the years I practiced medicine, those textbooks were written with data points that were coming from studies that involved only men. So when we look at the typical symptoms listed, it's for the typical male patient. So I would love for us to talk about typical symptoms of heart attacks for women, because women are not just, we are not small men, right? We are a whole different group of patients. And so we should study us and we should have talking points and guidelines that are specific. So I'm advocating that we have typical symptoms of heart attacks for women and get out of that whole atypical thing. But on that note, jaw pain may be one, nausea, just feeling really run down. But a lot of women will go to the dentist for jaw pain, and the dentist will say, well, nothing's wrong with your tooth on that side, nothing's wrong. But that may be her symptom that is related to a cardiac condition that needs a proper evaluation. So having some new workflows where we introduce that concept to our dentist and say, if you've got a 40-plus-year-old woman who comes in and you don't find anything orally with her teeth or gums that's causing the pain, don't just send her home and say, well, it's not your tooth, go home. Like that might be a reason to see if she could go and get some cardiology visit to evaluate her heart condition. Okay, next slide. So I am not here today to talk about hormone therapy. I really wanted to just stay within the realm of awareness. And really, I want you to leave asking a lot more questions than having necessarily treatment answers today. I will say to the group, and I would be remiss as a gynecologist who is a menopausal certified practitioner, that when we see those estrogen and progesterone levels fall, hormone therapy to replace that is the one of the best options. And the conversation changes for different women. So I encourage everyone to find a certified menopausal practitioner if you're having these symptoms, where you can go into a very detailed conversation about all the pros and cons. I also don't want to negate that the choices we make really do impact us in the world of chronic disease. So a diet, exercise program, smoking cessation, very important. And when I mean diet, I really do mean we have to stop eating fast food. We have to stop eating processed sugar. We cannot live on ultra processed foods. And so I don't want to preach on that today, but the choices we make really do matter at 40 and up. And we know that because you feel terrible, if you used to drink alcohol and you're older than 40, you might realize like you feel terrible and it's toxic and you just can't do that anymore. Sleep is very important. There are some studies that are now talking if a woman gets less than 5 hours of sleep per day, per night, it negatively impacts her heart health. And so those are the kind of talking points moving forward we should think about getting out into the public. And when I say protect your sleep, my grandparents finally slept in 2 separate beds because probably my granddad snored a lot. But already we as women have trouble sleeping through the night. So whatever you have to do to get your 8 hours or your 7 hours, protect your sleep. It's important for your chronic disease outcome. Decrease visceral fat. I know this group probably already knows what visceral fat is, but I want to make a point here. Visceral fat is not the fat on our bellies that you can pinch. It's the fat behind our fascia and our abdomen that's around our organs. And so as we go through menopause, the fattiness around all of our organs, especially around our hearts, really does increase our risk of stroke, heart attack, all those bad outcomes. So we've got to understand how estrogen and the decreasing estrogen levels increases visceral fat around our organs, which is one reason we have some of those poor outcomes. And then I already mentioned bone health, very important there. Okay. I don't know where we are on time. Y'all might have to give me a update. So when we think about resources, where I first became a certified menopausal practitioner was from a group called the North American Menopausal Society. They changed their name a bit. It's called Menopausal Society now. But I became certified about 7-8 years ago, and it was not trendy back then. But there are a lot more online resources, and so I listed a few here. Of course, in the beginning, they mentioned that I'm involved with ACOG. We definitely have a lot of literature on those websites. And then again, I'm going to plug this woman I've never met before, but the cardiologist, Jane Morgan. I know she's got some podcasts and things out there that's are specific to cardiac health for women over 40, and I think it's worth searching her out as well. I think that's all, guys. Thank you very much.
Thank you so much, Dr. Lord. This was a wonderful presentation. At this time, we will have our Q&A segment. If you have any questions for our keynote speaker, please feel free to drop them in the Q&A box at this time, and you will be acknowledged by one of our team members. For urgent medical-related inquiries, please contact your healthcare provider. Okay, I do see questions have come in. Okay, this is a question that we have received. This is such a timely presentation. Awesome job, Dr. Lord. If women are in the perimenopause period with symptoms, let's see, okay, come back. With symptoms and very infrequent misses, but labs values indicate menopause, which should we believe?
That is a great question. And if you go back to that perimenopausal graph where the hormone levels are all over the place, we could on any given day get a set of labs and it look like you are, by definition of lab work, menopausal, but then another week or two later get another set of labs that show that you do not meet the criteria by lab definition of menopause. And then you're right, we do take into account whether or not that woman is still having her period. There are lots of subsets of how to interpret lab results along with symptoms, along with other clinical findings. For instance, if a woman has had a hysterectomy but still has her ovaries, the way that we interpret those labs is different from the way that we may have a conversation with a patient who is still having an occasional period. So there's a lot to do in that one visit, and I definitely am not here to give independent or individual gynecologic advice, but my take-home point with labs is that one set of lab work, especially if we think the woman is in that 8 to 10 year of perimenopause, one set of lab work is not going to necessarily be helpful. And I did not typically get a lot of labs while I was in private practice, because again, I'm going to listen to the patient. If she's having all these symptoms that are within the years that we would expect her to be perimenopausal, then I'm probably going to talk a little bit more about that with her. If I think she has a gynecologic issue where she's having abnormal bleeding for some other reason, there's a whole pathway of testing and evaluation, especially if she's got her uterus, that we do not want to miss a diagnosis of like a cancer of the uterus. So I don't know that answered your specific question, but I would have you have that conversation with your physician about that.
Thank you, Dr. Lord. And as a follow-up to that exact question, do you ever recoup some of these hormones?
That's an interesting question. Recoup hormones. So as our ovary ages and stops producing those reproductive levels of estrogen and progesterone, we don't see the ovary by itself reverse. Okay, I don't know how, I've not been asked this question before, but it's an interesting one. And certainly if we remove the ovaries for, with surgery, we're not going to see any other organ that's really going to pick up producing estrogen, progesterone, and testosterone. Now, there are some other pathways of steroid production within our body. When we think about adipose cells are with some production of estrogen levels. So will our body naturally replace those estrogens to the level of our reproductive years? No, not after we go through menopause.
Thank you for that feedback, Dr. Lord. And we'll pose one more final question. Due to limited time, we will forward these other additional questions to you, Dr. Lord, and we will release at a later time with responses to those attendees that had additional questions. But for a final question, you received another wonderful compliment, Dr. Lord, on your presentation. This person said, I have all of the symptoms you read. My gynecologist and PCP suggested I do not use hormone therapy because of the cancer risk. What's your take?
That is the most common question that I get. So thank you for asking it today. I will ask you to go to one of those resources that I listed on the my like slide 13 and do a deeper dive yourself. I always ask my own patients to consider a second opinion when we were trying to make sure we were taking care of them and all of their needs. And so I will say that only recently, and even in the OBGYN world, are we talking more about all of those symptoms and at the younger ages that I mentioned, and what are some ways we use hormone replacement therapy and other medications to treat all of those symptoms that were listed. And so, unfortunately, there will be groups of practitioners out there that may not have the most up-to-date information. And so, in the sense of your overall health, sometimes seeking a second opinion can be helpful. But that is why I specifically said earlier, you may want to have this conversation with someone who was formally trained in menopausal healthcare, because the conversation has changed, but not all practitioners out there have changed their conversation. So be an advocate for yourself. Don't be afraid to ask a few people's opinion. I want folks to stick with FDA approved medications. So be careful, because there is a trend in menopausal care to offer modalities that are out of your pocket and not necessarily what we would recommend for those of us who are formally trained in menopausal healthcare.
Thank you, Dr. Lord. Great feedback, and this was a great Q&A segment. I will now turn it back over to our Bureau Director, Dr. Lowenthal, for closing remarks.
Yes, well, thank you. Dr. Lord, really want to thank you so much for shining a light on menopause and also your focus on the whole woman and not just small, thinking of a woman comprehensively and thinking of the health of everyone comprehensively. Your commitment to the health of Louisiana is outstanding. So with that, I also want to thank all of you for having participated in today's webinar. We know that wellness is a journey. Small, consistent steps can lead to big outcomes. So we encourage you to continue on your wellness journey. And please, there are many resources out there, including Well Ahead. So we look forward to hearing from you. And most importantly, as Dr. Lord said, give yourself grace and thank you for your participation. Over to you, Alicia. I think you're on mute.
Thank you so much, Dr. Lowenthal. Again, we do thank all of you for joining in today's webinar, and a huge thank you to our keynote speaker, Dr. Christina Lord. We are walking away today more enlightened and empowered. To find out more about Well Ahead and our numerous programs and services, please visit www.wellaheadla.com or contact us at wellahead@la.gov, or you can call 1-844-522-4323. Also, please follow us on all social media platforms to view today's presentation. Thank you, everyone, for helping us move Louisiana's health forward. Have a great afternoon.